I have the unique opportunity to introduce someone who is very well known to us. I call him a legend in pulmonary fibrosis. He's been with us from the beginnings of this fight against pulmonary fibrosis. He is the professor of medicine and director of interstitial lung disease at University of Washington, Seattle. Please welcome with me the amazing Professor Ganesh Raghu.
Thank you very much. Good morning, ladies and gentlemen. First of all, I want to thank the Pulmonary Fibrosis Foundation for doing a superb job in bringing us together. They always do a great job, and every time I come with them, it's bigger and better and beautiful. So I'm very privileged to be here in front of you, and thank you very much, the Pulmonary Fibrosis Foundation, the organizing committee, to be standing here in front of you. And also, thanks all of you to be here to listen to whatever we are saying, and hopefully we're all partnering and doing a good job. First and foremost, the clinical trial session has been here, and Blake did a fantastic job, and we are very indebted to patients here, there, everywhere in the world who are participating, partnering with us as investigators. We're thankful to patients, investigators, physicians, community care providers, caretakers of the patients, as well as sponsors, as well as industries, as well as agencies, including the FDA, who really care for the patients to get better and get better care in terms of new medicine is concerned. So my task, my disclosures are there. I've been a privileged consultant for many industries to help them design proper clinical trials. I've also got some research grants, and I'm a patient advocate for both care as well as clinical trials. So IPF progression of disease to this audience is clearly known that in the absence of another identifiable cause, the presence of any of the following changes is consistent with progression of disease, and that includes progressive dyspnea, progressive sustained decrease in pulmonary function test, progressive fibrosis, acute exacerbations, and ultimately death from respiratory failure. A few years ago, I was privileged to co-author with the very distinguished panelists there a perspective in terms of what really is meaningful in terms of primary endpoints for clinical trials. So what I'm going to be sharing with you is pretty much what we have discussed in this pulmonary perspectives, which was mainly focused on the clinical meaningful. What is clinically meaningful? Okay, it's unarguably appropriate primary outcome measures. To whom? Whose is it meaningful to whom? Is it to the patients, caretakers, physicians, investigators, regulators? Clearly, it is to the patients. So what is really the clinical meaningful is an important aspect of it, and what do we measure, and what does it mean is in terms of the IPF clinical trial is very, very challenging. First and foremost, I want to give a little bit of a housekeeping, so to speak, in terms of clinical trials. In terms of this terminologies of correlations and surrogation, what it really means. And so some factors to consider in designing phase 3 clinical trials. Correlations are not causal relationships, and it's simply to be related, to put or bring into a systematic relation. A relation or connection, it simply is that, a correlation between smoking and lung disease. For example, new data correlates with earlier disease. Correlates useful for disease diagnosis or assessing prognosis, and the measures of biologic activity, screening of proof of concept of trials, supporting endpoints, and valid surrogates or replacement endpoints. It's extremely important to know what correlates or surrogates in terms of when we design clinical trials. A surrogate is a substitute, a personal thing that takes place to the another. Correlates are not surrogates, and that's an extremely important situation that we as investigators and you as patients and others should be making and taking into considerations. So endpoints in clinical trials, again, clinical meaningful endpoint, a direct measure of how a patient functions, ability to perform activities in daily life, feels or survives. Well, it has to be well-defined, reliable, interpretable, has to be sensitive, and clinically relevant. We have learned a lot in the last 25, 30 years' time. I've been privileged to be participating in clinical trials, lobbying for clinical trials for 25, 30 years ago. And over the last 25 years, we have done so much in terms of partnering with patients and investigators and done clinical trials. There are over 50 of them, and these we have taken a rare disease and then done double-blind randomized clinical trials, placebo-controlled clinical trials. Hadn't been without the patient's participation, we would not have the success. One of the most important things that we have learned in the clinical trial is the natural course of the lung function decline in the placebo-treated patients. We have learned a lot from the placebo control arm. This natural decline of the patients with the forced vital capacity that we measure, called FVC, patients with IPF with mild or moderate impairment of the lung function, is known compared to the healthy subject over 60 years of age. The over 60 years of age, the FVC decline is about 30 to 40 cc per year. Now, look at this in the IPF patient population. The natural course FVC declines about 150 to 200 cc per year. Devastating. This is an important variable that we have to pay attention in terms of bringing that red line up towards the green line. And that is what it's all about in terms of designing clinical trials to be able to decrease the rate of the forced vital capacity decline. And that's one important aspect of a clinical trial. What we have done in the endpoints is we have looked at pulmonary function tests, we have looked at 6-minute walk test, acute exacerbations, and we've tried composite endpoints, extent of fibrosis, survival, patient-reported outcomes of quality of life, and circulating biomarkers is extremely important, at least. So what I'm going to be doing in the next few minutes or so, I'll go over one by one in terms of what we have done to understand which one of these endpoints are important for the clinical trials in making a decision. Forced vital capacity, FVC, you're all familiar with it. It's a distinct measurement of lung function widely used in monitoring objective lung function status. It is an indicator of disease progression, and longitudinal measurements have correlated FVC. Again, remember, correlation, FVC with survival in patients, and the one-year risk of death was increased with the change of the forced vital capacity decline. So FVC is a good endpoint. And this is the pirfenidone clinical trial that you're all familiar with. And if you look at the forced vital capacity decline, the pirfenidone patients who received the pirfenidone, the rate of the decline was slowed down. And that is also true in the nintedanib clinical trial, and the forced vital capacity decline over a period of 1 year time was slowed down. So the forced vital capacity in IPF was then initially thought it was FDA, just thought it was a correlate. And then the FDA looked at it very carefully in terms of the nintedanib and pirfenidone, and Banu Karimi Shah and Badrul Chowdhury wrote this perspective in the clinical trial where the forced vital capacity in IPF, the FDA reviewed it, and then in the right-hand column, the all-cause mortality in all of the pirfenidone trial and the nintedanib, it showed that there was a good correlation in terms of the all-cause mortality. And subsequently, the post-marketing data, the decline in the forced vital capacity is associated with decreased survival, especially if the FVC decline is greater than our 10 to 15% change. So FVC is clearly shown, so therefore it becomes an unarguably good endpoint to achieve in terms of the clinical trials. What about the 6-minute walk distance variables? How the patient conducts daily activities in clinic is clinically meaningful, of course. We do a 6-minute walk test, variables. Example, the walk test covered in 6 minutes. It does not fully capture the patient's ability of daily activities. And the testing procedures has significant limitations. So currently, there are really no other reliable direct measurements of the functional status of the individual patient with IPF. So here's the walk test. There are so many variables of the walk test that we should pay attention to it. Walk distance is dependent on how fast you walk, length of the lower extremity, tall person can walk, training, rehabilitation, whether the oxygen saturation, desaturation or not, whether the patient perceives the shortness of breath. It's all important, and the walk while breathing air versus supplemental oxygen, etc. There's so many variables involved in this walk test, and therefore it is problematic, and it is appropriate at the moment to use it as a secondary endpoint. Maybe in future, when the smartphones, the ambulatory devices, the actigraphs and such, that you can monitor how many steps you walk or how many activities that you do, maybe we need to incorporate this in daily clinical practice. The 6-minute walk in idiopathic pulmonary fibrosis longitudinal is a minimal important difference. Jeff Swigris, a few years ago in a clinical trial that we were involved, clearly brought up in this surface in terms of what is minimal important difference. Based on this particular study that Jeff did a fantastic job, that it appears to be 28 meters difference in terms of a clinically meaningful endpoint for the 6-minute walk test. And 6-minute walk test has been used in clinical trials. This is a clinical trial that I was engaged with, a study called the Pentraction study, where we used the 6-minute walk test. Shown high in the red is the patients who received Pentraction. You can see that the patients compared to the placebo, the blue, the patients who received the pentraxin, they walked at the same distance right from the baseline to the 28 weeks. And that was a placebo-controlled trial. And after that, we did another open label study. We extended the study, and here's the study of that. So here's the placebo. Here's the patients who received pentraxin. This is a 6-minute walk distance. And then, open label, they continue to maintain the stabilization in the walk distance. And the placebo people who received the pentraxin then also got stabilized. So 6-minute walk distance, if it is done right in properly designed clinical trial, may be a good clinical endpoint. So acute exacerbations. Acute exacerbations is something that we call when a rapid decline occurs in a patient who was doing otherwise well. And in an earlier clinical trial that I was involved in Japan, it was felt that 15% of the patients with placebo had an acute exacerbation. But all subsequent clinical trials, it hasn't been at about 15%. It's somewhere around 2 to 7%. Acute exacerbations is associated with worsened symptoms, high mortality, and impaired functional status, and it is clinically meaningful endpoint. The problem is, it requires adjudication. It requires an adjudication committee, and it is challenging to see whether it is really an acute exacerbation or something else. Therefore, there is a risk of measurement error. So then, the next one would be a composite endpoints. Progression-free survival. So if the disease progresses with the FVC, or if the survival, then why not use a composite endpoint? So composite endpoints are 2 or more individual endpoints combined together. Generally, one of the individual components is the driving endpoint. Progression-free survival has been used in clinical trials in IPF. For example, decline in FVC or death, whichever occurs first, should be constructed from a clinically relevant, meaningful endpoints or validated surrogates that are influenced by the treatment interventions. So all-cause mortality and all-cause hospitalization is an appropriate composite endpoint. So the risk factor for disease progression, recently we looked into a study which we was involved with, a study called Rainier study. The risk factors for disease progression IPF, this just got published in the Thorax a few days ago, is that death, all-cause hospitalization, adjudication, respiratory hospitalization was really associated with an accelerated decline over a period of 14 weeks. So if you have a person deteriorating in the 14 weeks, it has got very meaningful endpoints as far as composite endpoint is concerned. What about CT scan? The extent of the fibrosis is seeing is believing in terms of how much fibrosis is. Computed tomographic biomarkers in IPF has been now integrated in clinical trials. It's the future of quantitative analysis. The problem with it is fibrosis. Yes, fibrosis correlates with physiology. Patients with honeycomb change and a greater amount of fibrosis have increased risk of mortality. And that has been used in a clinical trial. This just got published about 2 months ago in the Lancet of Respiratory Medicine, a study sponsored by Fibrogen, pamrevlumab. Here's efficacy assessment will include spirometry and also standardized quantification volumetric CT scan of the chest. So here's a study that the quantification showed that with the treatment, the volume loss was less. So therefore, this is an appropriate endpoint to be used. But the problem with it is that the grading of the extent of fibrosis by quantification is still in development. And the quantification of the extent of fibrosis utilized as an endpoint is only in one study. So the interval duration, how often do we need to be doing it, is not known. The cost is an important aspect. And the radiation exposure is an important aspect. Then come to mortality. Of course, we're dealing with an unfortunate fatal disease. So any clinical trial which is going to enhance life is a good endpoint. The mortality, there's no disputes. It's a primary endpoint. Nobody's going to argue. It's got highest clinical relevance. It doesn't need adjudication. All-cause mortality is the cleanest, most easily interpreted mortality-related endpoint. And respiratory-related mortality should balance out. The problem is the disease is so heterogeneous. It's not feasible as a primary endpoint in this rare disease with mild to moderate disease. And it has been done, estimated it requires about 2,500 patients would be needed to detect a 25% mortality reduction with 90% power if you take patients with mild to moderate disease. There is, in fact, one trial that looked in terms of the mortality as an endpoint. That's called INSPIRE trial. That's the only trial to date with mortality as primary endpoint. A trial in IPF patients of similar size could be adequately powered if conducted on a proper duration. But a smaller trial can be powered if you take very advanced disease patients. So the range of the 2 to 17% mortality observed in other clinical trials is all for mild to moderate disease. But on the other hand, if you take advanced disease patients, then you may be able to power the mortality as a clinical trial. Showing here is an example. We used sildenafil for advanced patients with IPF. This study was the IPF NET trial we published in 2010. And if you look at that in the endpoint death and acute exacerbation at 28 weeks, there were 11 people in the placebo who unfortunately passed away compared to 4, and the statistical significance was 0.07. If we had just one more unfortunate death in the placebo, then this would have been statistically significant data. So in an advanced disease patients, you could include patients, and then you could theoretically have a mortality. There is another study that we did. This was published about over 10 years ago when we took very, very advanced disease patients. And this is, of course, a feasibility. These were people with FVC of 45% and diffusing capacity of 20%, 25%. So it is feasible that you can actually do a patient population with advanced disease for clinical trial. So all-cause mortality as a primary endpoint, is it feasible? It is only if you include very advanced disease patients. What about circulating biomarkers? Circulating biomarkers has a really nice, appealing buzzword. It is good if we can predict something that's going to happen. It's almost like you have a good prediction of a circulating biomarkers. Okay, this is going to predict. Unfortunately, there has been so many things that has been done, with the exception of CCL18, that has been shown statistically significant in terms of prognostic. Now, this is all post-hoc analysis of biomarkers of pirfenidone response. And recently, we published some data on another clinical trial where it didn't really match out. There are some limitations with the study where the conclusion is several biomarkers which we used, including CCL18, didn't pan out in this particular patient population. And there were several other biomarkers that we looked into it. So therefore, the circulating biomarkers, although very tempting to use in a plasma or a serum or a DNA, is at the moment is too premature to consider it as a clinical endpoint. So biomarkers and surrogate endpoints, Thomas Fleming and John Powers have written it very nicely. Arguments are classic positions that historically have been taken to defend the use of non-validated biomarkers as measures of therapeutic efficacy. The treatment effects on non-validated biomarkers have reportedly shown to yield misleading conclusions. Take the example of the INSPIRE trial. So the lessons from the interferon gamma trials is clear that the biomarkers didn't really work out in this particular clinical trial. So the war against IPF is ongoing. Where do we go from here now with all of the knowledge that we have with the clinical trials? True placebo controls are not practical at this moment, in my opinion, because we do have 2 good drugs that slows down the disease progression. The background therapy has become the standard of care. Nintedanib or pirfenidone is known to reduce the rate of FVC decline. Concerns, however, therefore, will be the reliance of the change in the slope of FVC decline to assess the treatment response of treatment intervention for primary endpoint of FVC as a single endpoint. So composite endpoint, I think it's about time to change from the FVC to the composite endpoints that are meaningful to the patients must be sought. The FDA's stand on it is substantial evidence is 2 studies replicating on efficacy finding. Situations in which 1 study would be adequate is a multi-center study of excellent design with highly reliable and statistically strong evidence of an important clinical benefit, such as survival. So the current status and understanding, as far as I am concerned, based on my knowledge and experience with designing clinical trials, and looking into the data very critically, as well as my current understanding with my interactions with FDA, is decline in FVC is still the appropriate endpoint. As far as the minimal important difference, we don't know whether it's 5 to 10% or is it absolute values. It requires 2 adequate, well-controlled trials, likely to be a year or longer duration, and a composite endpoint is appropriate, and secondary endpoints have to be used, and then the new treatment for IPF has to be with a standard therapy, but then if patients are willing to go on a true placebo, we need to be able to give them the appropriate treatment that are currently available if they deteriorate during the clinical trial. So the challenges for trial design primary endpoints This is a nice perspective that Rob Kainer and colleagues have written in terms of the challenges. And some people now want to use the daily home spirometry as an effective therapy to see whether the patients really need to go to the hospital or not. And this study particularly was done by Toby Mayer's group in England, where it showed that you can actually use the home spirometry for the first 3 months, and then there was an association meaningful endpoint. However, another clinical trial that Toby Mayer did very recently, published in the Lancet Respiratory Medicine just a few days ago, showed that the primary endpoint using this home spirometry didn't pan out. So the home spirometry at the moment is, I think, in my opinion, is an exploratory endpoint, not a primary endpoint based on this. So going back in terms of the primary endpoints in phase 3 clinical trials, it is true that we need to really be focusing on the clinical meaningful endpoint. Precision medicine is the new frontier in IPF. We need to know how do we incorporate this precisely in terms of the new frontier in IPF. Shown here is a fantastic study that Justin Oldham did a few years ago with the IPF NET clinical trial, that we do have a particular genotype polymorphism that NAC, if you use the N-acetylcysteine in a particular TOLI polymorphism genotype, these are the patients who might respond, and we used a composite endpoint in this particular clinical trial, or in the study. So we have designed a precision clinical trial using a pharmacogenomic approach for the very, very first time in terms of utilizing the pharmacogenomic knowledge and then precisely seeing whether a patient responds to the clinical therapeutic agents available. So what do scientific studies show? The key feature of the empirical testing is not that it is infallible, but that it is self-correcting. Our whole problem is to make mistakes as fast as possible. Science progresses precisely by trying as hard as it can to falsify its hypothesis. So the real-world data is the future. Here it is, you can probably get into the real-world evidence program. With this, I'm going to...
I'm presently approaching 69 years old. I was first diagnosed with IPF at age 63 and was given the impression that I had only 2 or 3 years to live. It was made clear to me at the time that there were presently no medications to improve my quality of life, much less increase survival. My doctoral work was primarily in statistical analysis, and as a result, I was predisposed to quantify my decline. Through my participation in a clinical trial and subsequent follow-ups, it became clear to me that the curves representing my quantifiable decline and that of the actual quality of my daily life were dramatically different. About 4 weeks ago, my FVC dropped to 48% and my DLCO to 29% of predicted values. Over the years since first diagnosis, I have experienced a modest decline in lung function, but nothing approaching the dramatic decrease as evidenced by PFTs. I have never been this age before and didn't know quite what to expect of it. Although more challenged than I had expected to be, I still engage in most of the recreational activities I've enjoyed over the years. Through this experience, it has become apparent that spirometry was measuring what is measurable, not necessarily what was meaningful to me. Living longer and enjoying life with my wife is what is most meaningful to me. Improvement in how we feel and function in our daily lives, and extending our lives is what is most meaningful to us as patients.
So this is what I enjoyed learning from patients every day. I learn from them and try to implement what I learn from them. So this is Mr. Narby was enjoying his life with his wife, as he said. In fact, when his oxygen was level, he wanted to do this as a flying in a little plane. And so with this permission and his family that I'm showing his slides, unfortunately, Dr. Narby passed away. So anyway. So I'm also very grateful to the Pulmonary Fibrosis Support Group of the Pacific Northwest that I founded back in 1988, and there's an extremely active group, and Mr. Sherry is here in this group as well, and he's going to be talking. So I am really very grateful to this group and all the other patients in the world from whom we learn and we try to improve, and clinically meaningful to patients with IPF is it's all about. Thank you very much.